Yeah, let's go.
So welcome everybody to the Stoke Mandeville Plastic Surgery Educational Series. My name is James Chan.
I'm Rebecca Shirley. I'm also a consultant at Stoke Mandeville Hospital.
And so we both work at Stoke Mandeville Hospital, and where we also host the National Spinal Injuries Centre in the UK. And we're thrilled today to have Natasha Van Zyl join us for our webinar. Natasha is a plastic and reconstructive surgeon based at Austin Health in Melbourne, and she's also a surgeon for the Victorian Spinal Cord Service.
We're really excited to have you here today, Natasha, because you're going to present some of your revelatory work on nerve transfers in tetraplegia that led to your Lancet publication last year. And this is something that we have a personal interest in and is very close to our hearts. So thank you very much for coming. For the audience, there is a question and answer box. Please do ask questions via that, not via the chat. And at the end, we will field some of your questions to Natasha.
We will also be recording this webinar, and you can find all our webinars on our YouTube channel. Just find Stoke Mandeville Plastics and you'll find all the videos there. So without further ado, Natasha, the floor is yours.
Thank you very much. Now, I just want to make sure that is my screen sharing with everybody?
Not yet.
Not yet.
Okay. All right. Let's go back again. And there we go. That should come up.
Great.
Great. Oh, just before you get started, Natasha, we've got the results from the poll. Can you see that? So most people never done tetra hand reconstruction. 3 people have occasionally done it, 3 sometimes, and 2 regularly.
Okay.
And 65% of people have never done nerve transfers for spinal injury patients.
Okay. Okay. Well, thank you, everybody. It is certainly a little bit unusual talking to an audience that I can't see. I hope that you find this talk interesting. It is, some of it is a little bit technical, so it sounds like I'm talking to a fairly broad audience, some without much experience, and some that are probably wanting to know more of the nitty-gritty. So please feel free to ask whatever you like at the end, and I will try and make a story out of this, so that the people who haven't had experience can at least sort of enjoy the journey of how this all came about. Thank you, James, for introducing me. I'm a plastic surgeon from Austin Health in Melbourne, and I'm presenting on nerve transfer surgery for tetraplegia, which is really an extension on the tendon-based techniques that we've used for so many decades. So as I mentioned, tendon transfer surgery has a long and salubrious history. It's served us very well from the sort of 1950s or so until the present day, and still has a role. But nerve transfer surgery gained traction really more in the area of brachial plexus reconstruction and peripheral nerve injury reconstruction. But in the last 10 years, it's been shown to be feasible, safe, and effective in many small case reports and small retrospective series. And a really great summary of all the work that's been done so far is in the article that I've got up on the screen at the moment by my colleagues, James Ledgard and Claudia Gershwin in Sydney. So if you want to know everything that's happened in this space until now, basically, that's the article to read. So nerve transfers for spinal cord injury are an attractive option because they allow direct reanimation of the muscle biomechanically designed for that function. You're not trying to take a tendon, a muscle that's designed for something else and put it in a new position. You're just waking up the muscle that was there to do that job in the first place. You can reanimate more than one muscle per transfer if you hook into a nerve that supplies, like the posterior interosseous nerve, which supplies multiple muscles. You avoid the technical challenges like tensioning of tendon transfers, and you avoid the complications and long-term outcome problems with tendon transfers, with tendons stretching out. Generally, the nerve transfers require smaller incisions and shorter periods post-surgery for immobilization, which is very attractive for the patient. But initially, especially in spinal cord injury, where we have quite a small group of people that all know each other very well, have been doing the surgery around the world, everyone's very protective of their patients, and anything new is met with healthy skepticism. And so, you know, there have been questions about the strength that can be delivered by a nerve transfer compared to a tendon transfer, questions about the reliability of those transfers. And really, hopefully by the end of this talk, you'll have an idea of, you know, who the better patients are to select, what are the nerve transfers that do better, and just an awareness of donor nerve health, which is a concept I'll expand on. Of course, with nerve transfers, you have to wait for the reanimation. You don't get the results straight away. So that is a little bit of a drawback. But, you know, for the right nerve transfer, it's absolutely worth the wait. The other issue, though, unlike tendon transfers, which can be done at any stage, in spinal cord injury, you really are better off if you can get your nerve transfers in early. That doesn't mean that you can't do a nerve transfer late, but you have to select that patient very carefully. So nerve transfers in spinal cord injury, you know, the common level of injury is sort of C5, C6, and generally what we're trying to reconstruct, same as when we were reconstructing them with tendons, is elbow extension, wrist extension, key pinch, grasp, and release or hand opening. And intrinsic function, which is, you know, not really that commonly reconstructed with nerves in spinal cord injury, because they're generally a higher level of injury, and we don't have enough donor nerves to get to that. But for the lower level injuries, they would also benefit. Now, I think that distinct from the patients who've had peripheral nerve injuries, who are having nerve transfer surgery, and also to a certain extent the brachial plexus injuries, the patients that are having nerve transfers in spinal cord injury are unique. And they are unique because they have two arms out of action, unlike a peripheral nerve or a brachial plexus, where they've got a perfectly functional other limb. And so what that means is that they take advantage of every gain, every tiny little bit of power that you give them, they use. And my experience in brachial plexus was that brachial plexus arm, no matter how much you did for it, no matter how many hours you spent working on it, they generally were pretty dissatisfied because they've always got the other arm to compare it to. In spinal cord injury, something is better than nothing. And these guys will use even fairly low MRC grade muscles or functions to do things. You know, for example, a grade 2 triceps is very useful. Across gravity, they can put their arm out in space. They can reach out to something by doing a little bit of a trick with their shoulder. They can also balance their arm up even above their head. And so they've got a much wider working space. And so an MRC grade 2 to anyone else sounds like a failure, but in a spinal cord patient, it's definitely useful. So, you know, our outcomes need to be focused on what the patient can do, rather than always being focused on MRC grade. You can do different reconstructions on different sides because you've got two different sides to work with. So you can focus on one side being more a strength side and one being more open hand side. And I'll explain what I mean by that later on as well. They're a small, well-connected group. So if you put your shingle up to start treating these patients, you do need to know what you're doing, because everyone will soon find out if your surgery isn't up to scratch. As I mentioned before, I do think it's really important to focus on functional outcome measures, objective power measures, and open-ended self-reporting. MRC grades, you know, we use them, but it really doesn't help us distinguish the quality of results. MRC4 covers about 95% of your strength range. you know, and so you can have an MRC4 which is almost full power, and you can have an MRC4 which is just some slight resistance after you've taken the gravity. But that looks the same on a paper, MRC4. Full range of motion, which you need for an MRC grade, also isn't necessarily always needed. And I think we do need to consider the functional range of motion rather than the absolute range of motion. And then the last thing that makes it challenging is spasticity. And with the increase in patients with incomplete injuries, this is becoming more and more of an issue. And we're finding that we're having to manage spasticity either with medications or botulinum toxin, or even with tendon lengthening surgery at the same time as trying to reanimate. Now, the nerves in spinal cord injury, what happens the way we think of, traditionally we think of spinal cord injury is that at the level of the injury, you have a lower motor neuron injury, all right? The nerves that are coming out there, the anterior horn cells are injured, and you get, you know, Wallerian degeneration and denervation of that nerve. And then above the level, we consider that the nerves are normal, and below there's an upper motor neuron injury. So that these nerves still got their anterior horn cells, they still have their reflex arcs intact, and so therefore they sort of they're a bit healthier than a denervated nerve. But the thing to remember in spinal cord injury is that your donor nerves are just above the injury and are just below. The injury itself is usually a blunt injury, and so there's a sort of a spray effect or a bruise effect up and down from there. And what that means is that if there's injury to anterior horn cells up above the level of the injury, you've got a mixture of normal and compromised axons coming out of that nerve root. The donor nerve may be compromised, and that may have implications for outcome, because if your donor nerve isn't ship shape, then you know it's hard to get a good, powerful result. Now, if the recipient nerve is denervated, or partially denervated, the recipient nerve may have some element of upper motor neuron injury and also some element of lower motor neuron injury, then of course you're subject to a timing issue. You need to get you need to get that transfer in as soon as you can. And in spinal cord injury, in a complete injury, that's any time from sort of 5 to 6 months, and probably not later than 12 months if you can possibly help it, in order to capture and reanimate all of those denervated nerve fibers. And just to sort of prove that point, in some work that we did looking at the histology of nerves, donor nerves and recipient nerves that we were using for transfers in spinal cord injury, we showed that 73% of our donor nerves showed changes and 88% of our recipient. And those sorts of changes were things like thickened epineurium, a reduction of axon density, demyelination, and other changes like inflammation, necrotic foci, and collagenous perineural matrix. Now, we kind of got into things inspired by the work in brachial plexus and working with spinal cord injury. We wondered sort of around about 2011 if we couldn't apply these nerve transfers to spinal cord, and we started doing a few transfers and then eventually put together the triple nerve transfer, which those individual transfers had been previously described, but all we did was put them together as a combination to reconstruct elbow extension, grasp and pinch simultaneously, similarly to the way that we were doing it with tendon transfers. And our first patient that we did we did bilateral triple nerve transfers for, did extremely well. And because of that, there was then a lot of interest in nerve transfers in our local community, and we got a lot of referrals. And so at that point, we really had to set up a study so that we could prospectively investigate what we were doing. because we didn't have anything much to base it on, as I say, other than a few case reports. And so,
Okay.
oh, sorry, yes. That is actually meant to demonstrate, I'll show you the video again. Up to your mouth. That is meant to demonstrate this patient who's had a triple nerve transfer using his elbow extension, his hand opening, and his grasp in one video. I'll just show you that again.
Okay. And just lift it up to your mouth.
So that's when we set up the study that was eventually published in the Lancet, so that we could prospectively examine a group of patients that were consecutively referred to us and examine in detail the clinical and functional outcomes. So the patients were recruited over a 3-year period, and each patient had a minimum of a 2-year follow-up. Patients of any age or mechanism of injury were included as long as they were less than 18 months post-cervical spinal cord injury, because we didn't want to be looking at late nerve transfers and the outcomes there. We wanted relatively early. A motor level of C5 or lower at the time of surgery, and they had to be able to comply with the proposed intervention and therapy. They were excluded if they had an ABI with any sort of cognitive or neurological impairment, a pre-existing or simultaneously attained peripheral nerve injury or brachial plexus injury, or decreased passive range of motion across a joint plan for reanimation. All patients, sorry, I'm just going to take the poll there. All patients underwent single or multiple nerve transfers in one or both upper limbs, and all patients had preoperative EMG studies on all the muscles of the prospective donor and recipient nerves. And we used nerve transfers to reconstruct elbow extension, the teres minor and or posterior division of the axillary to the long and medial head of triceps, hand opening, which was a supinated to pin, and a grasp and pinch, which was either, we used 3 different potential donor nerves, but all of them onto the anterior interosseous. So either brachialis or ECRB or supinator. So depending on the level of injury. Now, some participants, in their other hand, had tendon transfers for grasp and pinch, and they were standard tendon transfers used in tetraplegia. Often we use brachioradialis to flex a pollicis longus for thumb pinch, and ECRL to FDP. Now, we did tendon transfers in the opposite hand to give them a different style of hand, but they would have had nerve transfers in the other hand, and both sides they would have had nerve transfers for hand opening and nerve transfers for elbow extension. Some participants had tendon transfers to restore wrist extension, but I think it was only one in the study. All patients were operated on supine under general anesthetic with a single dose of muscle relaxant and no tourniquet, because the tourniquet interferes with your ability to stimulate the nerve and accurately determine the threshold of your donor and recipient nerves. Patients are in a sling for 7 days post-op, but only in a splint if tendon transfers are used and if undertaken at the same time. So this is it's a little bit blurry, I'm sorry, this cartoon, but it's in the paper if you want to have a look at it. But just a little cartoon showing the axillary nerve and the sort of major portions of the axillary nerve, and the anterior division, the posterior division, and the teres minor. And the teres minor nerve is just flicked down and put into the long head of triceps. Often there's a little fascicle, 2 fascicles or branches that run together, the long and medial head, and we're plugging into there. This is what it looks like when someone's having a teres minor and also an ECRB to AIN. And then you've got the brachial vein, the radial nerve. This is the triceps nerve that's just being pulled off the radial nerve. and doesn't show it very well, but there's the axillary nerve looped, the anterior division's looped here, and down at the bottom is the teres minor. Nerve transfers for hand opening. Is the supinated to posterior interosseous nerve, and that's done in our facility through an anterior incision. Forearms rotated a bit there, but we do actually do it from the back, from the front, not from the back as described originally by Bertelli. And you can see here the superficial radial nerve, the nerve to ECRB, the pin, and the two supinator nerves flanking it on either side. You cut the recipient nerve proximally and the donor nerves distally, and coapt the two together. Nerve transfers for grasp and pinch, as I say, are brachialis if you've got a higher level of injury, but if you can get a little bit lower and closer to your anterior interosseous nerve, then the ECRB, which you find in the forearm, very close, well, we've just seen it actually here, the ECRB nerve. And this is why we go from the front, not from the back, because we're often using the ECRB onto the anterior interosseous, and we can do that through the same incision. Or the supinator nerve, which is also, as you can see in that previous photograph, is sitting right there. So that single anterior incision is a good place to go for your nerve reconstructions. Now, here's a patient who's had ECRB to AIN, that's that one there. And just recently, we've been adding in also branch to pronator teres to FDS to try and power up the grasp even more. And this is our incision that we use for the supinator to pin. And we extend it up here if we need the anterior interosseous nerve, because we have to neuralize up fairly proximally in order to flick that across so that it can reach the ECRB. And that's just for another something else that we sometimes do, not a nerve transfer. So we looked at strength, MRC grade in the old-fashioned way. We looked at grasp, we looked at pinch, we looked at first web space opening, which is demonstrated here from the ulnar nail fold to the radial nail fold of the index. We looked at sensation, we looked at pain, proprioception, complications and adverse events, and patient satisfaction. In terms of functional outcome assessment, we looked at the Action Research Arm Test, Canadian Occupational Performance Measure, the Grasp Release Test, and the Spinal Cord Independence Measure. Fairly standard analysis with medians for skewed. Most of our data is skewed because it's a small sample. Wilcoxon signed rank test to assess the difference between pre and post surgical ARAT, GRT, and COPM and web space opening, with a usual threshold for significance and a Spearman's rank order correlation coefficients to assess relationships between measures. So in the end, we had 13 participants with full follow-up to 24 months, which was 22 limbs and 50 nerve transfers, which was a big number in the literature. Really, most of them were very small series or single case reports. Mean age at injury was 27. Patients were C5 to C7, all motor complete, or the International Classification Group 1 to 5 for those that work in this area. Time to surgery on average was 10 months, and 77% male, 23% female. All our patients were traumatic, but that's just because we tend to see more that profile of patient. About a quarter each of falls, diving, sport, and motor vehicle accidents. So looking just at the MRC to start, you can see that for triceps in this top row, we did 15 transfers, getting a median MRC grade of 3, which is which is comparable to the systematic review done by Hamau, which had 3.3 for the tendon transfers. I think that if with triceps, if you can be a little bit selective about the patients that you offer nerve transfer for, which is not what we were doing at this stage. We were still learning, and so it was all, you know, all comers. We'd probably be sometimes a little bit more selective. Now, I think that absolutely our outcomes are equivalent, whether we use nerves or tendons. For the supinated DePin, which was reanimating the extensors, EDC, EPL, APL, ECU, we did 21 supinated DePins, and you can see that we're very reliably getting against gravity or better extension. ECU is very, very useful because it centralizes the wrist. Otherwise, these patients tend to get a bit of radial deviation when they extend because they're only relying on ECRL and ECRB. And, but that's very useful just to centralize the wrist and increase your grip strength. In terms of transfers to the AIN, which of course picking up FDP, beg your pardon. That should say FPL, not FDP. I've divided them into proximal nerve transfers, distal nerve transfers, and tendons. Now, proximal nerve transfers is a brachialis to AIN. So the brachialis is, of course, higher up in the arm, and the distal nerve transfers are ECRB and the supinator nerve, which, of course, in the forearm. So a much closer distance, much less of a distance that the nerve has to travel to reach its target when it starts off with a donor that's actually in the forearm, and then tendon transfers. And you see, again, here you can see we're getting exactly the same number, but I can tell you that, that we do find that the proximal nerve transfers are not as strong, and you can see here in the interquartile range that that is reflected, but in our actual final number, there's no difference between tendons, distal nerve transfers, and proximal nerve transfers. We did show a difference with FPL, only getting a median score of 3 for our proximal nerve transfers, and then 4 and 4 for distal and tendons. And yeah, they're not the same. I'll show you a little bit more detail with the objective power measures later. First, web space opening is much improved with nerve transfers for hand opening, particularly when you've used nerve transfers for grasp and pinch as well. So not only are you've got nerve transfers for hand opening, but you've also got nerve transfers for grasp and pinch. That makes for a very supple, open hand, and our patients are going from an average of 10 millimeters of first web space opening pre-surgery to 110 millimeters post-surgery when they've had nerve transfers for grasp and pinch on their hand. Now, when we've reconstructed them with a supinated or posterior interosseous nerve for hand opening and tendon transfers for grasp and pinch, then they still get an excellent web space opening, but it's not quite as good, 92.5. So when you look at the more objective strength measures, you can see that the difference between a proximal nerve transfer to the anterior interosseous nerve, so brachialis to anterior interosseous, versus a distal nerve transfer like ECRB or supinator to the anterior interosseous, versus the tendon transfers, the standard tendon transfers, that the grasp strength increases as you move through that list, 2.8, 3.2, and 3.9, but they all score a 4 on the MRC. Pinch as well, with the proximal nerve transfers is weaker, nearly double, well, more than double actually, in the distal nerve transfers, and a bit more again for the tendon transfer. Picture on the side is just showing you the kind of range that you get with bilateral nerve transfers for hand opening and hand closing. In terms of functional improvements, The ARAT score increased significantly from 16.5 to 34. The GRT, which is a grasp release test where you're picking up objects. It's the number of objects you can pick up in a particular time frame and release again, scoring 35 to start before surgery and 125 at 24 months. Copham performance going from 0.4 to 7.4, and Copham's satisfaction going from 0 to 7.4, with all of those results being significant. The spinal cord independence measure is what it describes. It's looking at functional abilities in patients with spinal cord injury. It's specifically designed for spinal cord injury. And you can see that, and they measure minimal detectable change, MDC, and minimal clinically important difference. And you can see that for self-care and mobility in the room and the toilet and the total skim score, we get more than the minimal detectable change and the minimal clinically important difference for the last two. These other, this of course is changing, just not anything to do with our nerve transfers. That's just a natural improvement, and of course it's not significant. Mobility in and outdoors, we didn't quite show a significance change that was significant. In terms of satisfaction, satisfaction was highest for the supinated post-interosseous nerve transfer. So patients like that one the best, especially if nerve transfers were used for grasp and pinch as well, because then they really get beautiful hand opening. And they like that hand. Actually, I'll talk about that again a little bit later, because the hand opening and being able to use the hand in the open position is an extremely important function for us these days, more so than before, because of the use of electronic devices. Satisfaction with hand opening correlated strongly with first web space opening. So really, if you're going to measure even just one thing about the outcomes for your hand opening nerve transfers, web space opening is where you should be focused. Satisfaction with tricep surgery correlated strongly with tricep strength, which is not surprising. Satisfaction with grasp and pinch correlated moderately with grip strength and lateral pinch. No participant regretted having surgery or would have it again and recommend it. However, satisfaction did not always correlate with performance. So sometimes we had patients who did extremely well, whose satisfaction was not what we would expect it to be. And that just points to the fact that satisfaction is really a factor of expectation, or relates more to expectation than to performance. So in terms of problems, there were no patients who had, if they had pre-existing musculoskeletal pain, there was no participant that had an increase in musculoskeletal pain. There was some patients had neuropathic pain, and after the surgery, by 24 months, this pain had either lessened or completely disappeared. So nobody was left with more neuropathic pain after the surgery than before the surgery. We had 4 out of 50 nerve transfers fail completely, with an MRC grade of 0 or 1. And 2 of them were transfers for elbow extension, and 1 was a brachialis to anterior interosseous for grasp and pinch, and 1 was a supinated to pin for hand opening. And the thing that all of those patients had in common is that at their initial assessment, their initial ASIA assessment, they were all a C4 level of injury, which then recovered to a C5. And those donor nerves, all of our donor nerves are basically supplied by a C5 to 6 nerve roots. And so these patients' donor nerves were involved in the injury and then recovered, and so they may be already down, they've been downgraded. And so when you've got a downgraded donor nerve which is recovered, so clinically it looks like it's functioning normally, but actually it's only maybe running on a certain percentage of its axons, and then you cut that nerve and you transfer it to a recipient, and you lose axons across your coaptation, and that's when you start downgrading your results. So a donor nerve that's always been functional. A muscle has always been present. It's always been powerful, 5 out of 5 or 4 out of 5. That's the muscle whose nerve is going to be a good donor nerve. 2 patients experienced temporary wrist weakness post spin procedure, and I think that's because of either a bit of neuropraxia to ECRB, and also to do with our, in this case, actually, it was to do with our practice of doing simultaneous tendon transfers. And when you do tendon transfers that reanimate the thumb and grasp, you basically take a wrist extensor and you flick it around to the front for grasp. And so you've put them down to just one wrist extensor now, and you've put that power onto the volar side of the wrist, which means that it tends to pull the wrist down a little bit. And so you just need to be a little bit careful about that if you're doing simultaneous tendon transfers and spin nerve transfers. 2 patients with sensory disturbance, neither of them had felt that interfered with their function, and there were no reductions in donor movement power as synergist muscles are left intact. So of course, muscles that we take the nerves away from completely are denervated, but we always leave a muscle behind that's doing the same thing. For example, if we take the supinator nerve, we leave biceps behind to supinate the forearm. How are we doing for time? Okay, well, I think a few things to discuss, and I might try and make this a little bit briefer than maybe I've got it set out for. Just for those of you, and this really I think is probably more relevant for the people that are actually doing the surgery, just wanted to briefly talk about the various nerve transfers themselves, then talk a little bit about patient and nerve selection and the ideal conditions for a nerve transfer in spinal cord injury, and then the suboptimal conditions, then our key learnings and some future opportunities and challenges. So let's see if we can get through this. Nerve transfers to elbow extension in spinal cord injury are attractive because of the minimal mobilization. When you do a tendon transfer, you're 8 weeks or so in a Bledsoe brace, which is really quite cumbersome. Whereas a nerve transfer is just a little cut in the armpit, and you wear a sling for 7 to 10 days and you're done. So smaller incision makes bilateral surgery a lot easier, and failed transfers can be salvaged with a deltoid to triceps tendon transfer. And here's a patient demonstrating the power in his triceps, holding a 1 kilogram weight after a teres minor to triceps. Definitely though, particularly for the patients having elbow extension reconstruction, a lower initial motor level of injury, C5 and C6, not a recovered C4, are the better patients for this particular transfer. If you've got light limbs, you're doing better too. Big heavy limb, much harder for them to get a good extension. I mean, with a tendon transfer, that would be the same too. But I think particularly for nerves, you need to get in before 12 months. And like any donor nerve, if it's got a low stimulation threshold, it stimulates at 0.5 milliamps, and the muscle, when you stimulate the nerve, the muscle goes for a full range of motion. You know that, then you know you're looking at a good donor nerve, and those are the patients that are going to do well. Nerve transfers for hand opening. Well, nerve transfers for hand opening in spinal cord injury has been an absolute game changer. And this was an operation described by Jamie Bertelli. Active hand opening was not previously achievable with tendon transfers in C5-6 spinal cord injury. You actually reanimate 7 muscles with a single transfer, which you know, far outdoes the 1 tendon, 1 function rule of tendon transfers. Reanimating APL gives you a lovely wide first web space, and those of us who work in spinal cord reconstruction would realize that before the advent of the supinator pin, there was a lot of work spent trying to stabilize and position the thumb, fusing CMC joints, which we don't have to do anymore now with the supinator pin. The ECU reanimated gives you more centralized wrist extension. You only need an MRC grade of 3 for hand opening. You don't need to lift anything up with your hand. You just need to get your hand open. There may be some differences between digits in terms of range and strength, and you've got to watch out that you don't neuroprax the ECRB while you're doing the operation. But hand opening is just essential these days for using computers and using devices. And this is a picture of a whole lot of supinated pins, so it gives you an idea of you know, the sort of range that we get. They don't all look perfect. Some of these patients have got spasticity, so their hand doesn't open properly. I'll show you a video of that in the next slide. But just to give you all of them, so this is their hand at rest on the left, and then just to the right is them in full extension. They're not trying to make a fist, they're just at rest and then extending out. And all of them have more ability to get their hand around something after the supinated pin than they did before. So this is the difference with spasticity. This patient has had nerve transfers for grasp and pinch and for hand opening, and gets a really nice hand opening. His thumb IPJ needs a bit of balance to it. It's coming in too much, but then this is compared to the spasticity, where you just can't get that same PIP joint extension that you get when you don't have spasticity. In terms of grasp and pinch, the brachialis to AIN is less reliable and less strong because it's further from the recipient nerve. You've got to dig around in the median nerve to find the anterior interosseous fascicle. It's not the true anterior interosseous fascicle. I think sometimes it's still being formed. You have the possibility of interfering with sensation and with pronation if it's present. But it's the only option in a high level patient. So it's definitely not a transfer we're chucking out. We're just saying that if we can do a distal transfer, we will. ECRB and supinator are our preferred donors if you've got a low enough level of injury. And then if you can double up or triple up, adding other nerve transfers like pronator teres to FDS to try and target FDS as well as FDP. And maybe, so you did an ECRB to AIN, you did a pronator teres to FDS, and then maybe even you did a brachialis to ulnar nerve, which was recently described, to try and target FDP to the ring finger and little finger. Adding an intrinsic reconstruction adds a lot of power to the hand. And consider using tendon reconstruction for grasp and pinch in one hand and a nerve in the other. And for these reasons, I'll get this gent to explain to you why he's had nerve transfers for hand opening on both sides, but he's had tendon transfers on the right for grasp and pinch and nerve transfers on the left. And he explains why he likes having two different styles of hand.
So Jack, you had some surgery 2 years ago to reconstruct hand opening. On the left-hand side, you've had nerves for hand opening and nerves for hand closing. And on the right-hand side, you've had nerves for hand opening and tendons for closing. Can you tell me about your two hands, things that you can do, things you like, things you don't like?
My left hand's good in that it opens and way better. It's not quite as strong.
Yeah.
My right hand doesn't quite open as good, but it closes really strong.
Yes.
And I can hang on to pretty much anything.
Yep.
I can hold and drink stubbies, no worries.
Yes.
So like that, like the fact that this one is a little bit more openy.
Yes, okay. So what sort of things do you like to do with your left hand that you can't do as well with your right?
Left hand's better for reaching out and picking things up.
Yes.
Or even just reaching out, shaking someone's hand.
Yeah, okay.
The left hand's actually better.
Yes.
Yeah, just that you can get around things better with it.
Yeah.
It opens better.
Do you use electronic devices? Do you use an iPad or a phone or anything like that?
Yeah, only my phone mainly.
Okay.
And I use it, hang on to it with my right hand and
yes, and use it with your left.
Use it with my left.
Were you left-handed or right-handed before the accident?
I was right-handed.
Okay. So even though you're right-handed, you're using your left hand to work your phone.
Yeah.
Yeah. Okay.
It just, I don't know, that's just the way it sort of played out.
Yep. Okay.
It works better.
Beautiful. Anything else you want to say?
No, only that I'm wrapped with what I got. I would have loved it to be even better, but I'm wrapped with what I got compared to what I had.
Fantastic.
Going from completely no hands to this has been great.
All right. Thank you, Jack. So
So just to summarize, the ideal patient and the perfect conditions, if you like, for a nerve transfer are a patient who's cooperative, motivated, with light limbs and supple joints, with a low level of injury, C6 or International Classification Group 4. The muscle of the donor nerve must always have been an MRC grade of 5 or maybe 4. No recovered nerves, nerves that weren't working that are now better 6 months later. The EMG of those muscles should only have 1 or 2 plus fibrillations with normal or reduced recruitment, but not markedly reduced or discrete recruitment. Intraoperative stimulation the nerve should stimulate at a low stimulation threshold, 0.5 milliamps, and have good movement. The muscle should create good movement on stimulation. There should be no additional donor nerve injury like a brachial plexus injury or compression. And in terms of nerve transfer selection, choose the nerve donor that you've got that's as close to the target as possible, and put as many axons as you can into that nerve, and double up and triple up if you can, for example, when reconstructing grasp. And timing, do it early, ideally at 6 months in a complete injury. Now, the less than perfect conditions are basically the opposite of everything that's on the previous slide, but that doesn't mean that you shouldn't do nerve transfers in these patients. If you've got few or no options with a tendon transfer, then something is better than nothing. And like I said at the beginning, a lower MRC grade is still functional. So I would encourage you to still do the surgery, but obviously preparing your patient for a lesser result and not introducing them prior to surgery to your best result. So, push the limits, because they will use everything that you give them. They will take advantage of every tiny gain. And you just explain to them that the prognosis is more guarded. And don't compare these patients either when you're writing about them or when you're just thinking about them yourself to the patients that fall into the category described on the previous slide. So we've been doing nerve transfers now for 9 years, and these have been the things that we've noticed. First of all, there's a much better uptake of surgery. Tetraplegic people are coming and having surgery in much higher numbers than they did when there was just tendon transfers available, because of the need for early surgery with nerves. And we think that's a good thing, of course. We can now offer reconstructive options in a higher level of injury than we could do with tendon transfers. We have, nerves that are buried away, teres minor, supinator. We could never use those muscles, but they're available to us as nerves. Even modest results can improve function and independence. Nerve transfers are often preferred by patients because of shorter immobilization times. We can now have effective active hand opening, which is a massive improvement on the previous group of patients. Donor nerves closer to target are superior. Bilateral surgery is well tolerated and can be safely combined with tendons. In this study, tendons for grasp and pinch were stronger than nerves for grasp and pinch, but we were only using a single nerve transfer in the study, and we're now not doing that anymore. One hand tendons, one hand nerves for grasp and pinch is a good idea for the reasons described by my patient earlier. And nerves offer a different style of hand, more open hand. It's a hand that's better for human interaction. When you interact with somebody, you generally do it with an open hand. If you touch someone or shake their hand, you're not doing it with a closed fist. And yeah, doubling up or tripling up grasp is increasing power attainable with nerves. Future opportunities and challenges. I think we need to set up close collaborations with our spinal cord units, because it's very important that we get these patients early. We have a standing order that everybody who comes through the spinal cord unit comes to see us at the upper limb program. They don't all need to have surgery, but everyone sees us at 3 months. We need to think about algorithms for combining nerve and tendon transfers tailored to patients' needs. We need to look at in more detail, and we are doing some of this work now, so hopefully we'll have some more information for you in the next year or so, correlating clinical neurophysiological and histological findings to outcomes to ascertain the predictors of good outcomes. We need to combine with other technologies like implantable neuroprosthesis for trunk stabilization, because if we can get good trunk stabilization and a working arm, then we really are making an enormous difference for the quadriplegic patient. We need to integrate the management of spasticity into upper limb reanimation. And we need to examine the effect of preoperative interventions to maximize outcomes. For example, preoperative electrical stimulation to maintain nerve health prior to nerve transfer surgery. Thank you very much.
Thank you very much, Natasha. There's so much for us to think about, and such an exciting time for us when we're trying to really take our service forward and tetraplegia within the UK. We've got a number of questions. In fact, James and I have loads of questions to ask. We've got some questions from delegates as well. But I wonder if I could just start by asking you, you didn't talk at all about technical aspects of this surgery. Yeah. Is there anything that you think is, I've heard you say before that it's important to get it right, and I just wondered if you had some sort of key points of what you think is critical when it comes to nerve coaptation.
Oh, okay. Look, you know, I think the getting it right is actually about patient selection and choosing the right combination of nerve and or tendon transfers. And knowing, you know, when you say you can safely go in early to operate, when you need to wait, you know, it's all those kinds of sort of pre-operative decisions that I think are really critical. The operating itself is really quite basic. Once you've made your decision, it's just a matter of going in there and finding the nerves and joining them together. I guess I would say that you shouldn't use a tourniquet, because you looking at the threshold that you need to stimulate that nerve gives you information about its health. And so for your donor nerves, you know, you want them to be stimulating well. And with your recipient nerves, you want to be sure you haven't got it wrong. And, you know, unlike in brachial plexus surgery where the nerve's always dead, we are lucky in spinal cord that a lot of the time they do stimulate. And it gives you great confidence, you know, when you're doing the surgery to be able to stimulate the nerve and see it moving the right muscle. So operating without a tourniquet is not as daunting as you might think as well. It's just a matter of proceeding slowly, using careful diaphragmy. And if you haven't done it before and you just approach it with great carefulness and patience, you will notice that it's actually not really that much different to operating with a tourniquet. And then it's just when you cut the nerves, you want to have enough length on the nerves so there's no tension on the nerves. So as Susan McKinnon always says, donor distal, recipient proximal. You know, get that extra length. Make sure your nerve's doing a little S bend. And then take your arm through the range of motion afterwards so you can make sure there's no tension on it. And I just sew them together with an 8-0 or an 9-0, put some Tisseal over the top, and then sew them up and make sure the registrars don't rub them down too hard at the end with the wet pack and rip the nerves apart. You know, make sure nobody picks the arm up and puts a blood pressure cuff on the arm or lifts them under their arm. People have got to, and so I just put them in slings so that people know not to handle their arms at all, because you're just worrying about those little nerves being avulsed. But we don't splint them. We just put them into slings.
If you have a mismatch of fascicles on one side to the other, anything particular you do then?
It is a bit more challenging, and you've just got to try, and it's like, you know, putting a vessel together where you've got a mismatch. You've got to, you know, take wider space bites on the circumference of the bigger nerve, and I'll usually put, you know, 2 lateral sutures in, and then fill in the gaps, you know, do the front wall. Actually, I used to do the back wall, but actually now I do 2 lateral, front wall, flip it over, because it's nice and stable now, because you've got the front wall all nicely done, and then flip it over and do the back wall. But whatever works for you. Because what's also hard is when you've got two little supinator nerves, you know, going into one, and it is a little bit fiddly, but you know, there's nothing mysterious about it.
Do you ever use an end to side anastomosis?
No, I kind of, my philosophy with nerve transfers is that you have to make the call. You can't have it both ways. You know, you've got to decide. If you decide the patient needs a nerve transfer, you've got to cut the nerve and do it properly, and that you can't sort of hedge your bets. I'm not a fan of the end to side, except to sort of park a nerve. You know, park the distal end of a. And not that I do a lot of sensory transfers, but if I had a distal end of a sensory, a nerve that I cut as a donor nerve for a sensory transfer, that distal end of the nerve that I've left behind, I might put, you know, end to side onto an adjacent sensory nerve, just in case some axons decide to head down that distal nerve, which would otherwise now be numb. Otherwise, I don't really use end to side.
You don't do a fascicular repair, then it will be purely the epidural coaptation.
No, I don't do a fascicular repair. No, it's just epidural. Yeah, because you know, you're not when you're repairing a nerve, like a big nerve, particularly a median nerve or something, you've got fascicles that you can line up, because you have one end that belongs to the other end. You don't have one end that belongs. These are two separate nerves. They're often, you know, one small, one big. You know, two separate fascicles. They don't belong together. So I don't. Yeah, I just epidural repair. Yeah.
Can I ask you about, you talked about optimal conditions. In those patients that have those conditions, do you find your outcomes very predictable? You said that it was a very small minority that didn't have recovery, but do you find when you see them at certain months that they tend to behave in a very similar way? Or do you feel surprised sometimes by different rates of progress or sometimes late recoveries?
Yeah. I think that I feel pretty secure that they're going to get a result, and probably get a reasonably good result. But it is interesting that sometimes people seem to recover quicker than others. And sometimes you do get a bit of a surprise, either early or late. I mean, partly it's to do with how carefully you're looking for a flicker of movement in your recipient muscle. And the way to elicit a flicker of movement in the recipient muscle is generally to get them to perform the donor nerve muscles movement, so, you know, say supination, against resistance, and watch for slight extension, usually in the thumb. Okay, so you get them to resist, to supinate against your resistance, and then you look for a little bit of a movement. That's the way that I find you can sort of pick up the very earliest sort of subtle changes. But if patients aren't instructed to sort of look for these movements, they can literally recover fully without noticing that their nerve transfer is working. And I just really illustrated by a patient of ours who had their surgery in Melbourne. They were from Queensland, and he was a 18-year-old boy, and he, you know, went home after his nerve transfers. He had supinated to pin nerve transfers, and he was too busy learning how to drive and do this and that and out with his friends. And we contact him, and he contact us and say, oh, no, nothing's working. Finally, we thought there's no way this isn't working, and we got him up on a telehealth, instructed him to do it, and his hand just opened up, and he was like, oh my gosh, did not know that you know, would do that. I didn't know that it could do that. And then we said, well, why don't you try that on the other side? And he went, oh my gosh, you know. Now, obviously, clearly not the smartest guy we've ever operated on. But I did tease my therapists about that, you know, that, oh, he didn't have any therapy. And he just kind of did it when given the right instruction. So yeah, sometimes it's a combination of people not noticing that something's happened, or clinicians not noticing that something's happened, and it actually has. And also there is certainly some variation in how quickly people recover. And maybe that's to do with the donor nerve, you know, maybe it's to do with donor nerve health as well.
So Natasha, all the results you've you published in the Lancet and you presented here, they are 2-year follow-ups, and now it's been another year and a bit since then.
Yeah. Yes.
Has the patient continued to improve, or any comments?
Yeah. Look, we're going to follow up everybody again with the exact same battery of follow-up tests at the 5-year mark. So we're just starting to do 5-year assessments on some of those patients. So you'll have to wait for that outcome. And I think we'll find that there are some subtle changes, but I don't know that there's going to be a huge change. But I don't know at this point. I mean, this is the thing about nerve transfers. We are still learning about it. You know, is there capacity for nerve transfer to keep improving, you know, years down the track? I think probably there is, but it's not a massive change. Definitely most of the change is occurring in the first 24 months. And I think it is important to give patients at least that long though as well. Maybe not so much for supinated to pin, but certainly for brachiatus to AIN, they need about that amount of time to really say that is your final result.
What are your thoughts about smoking?
If a patient is smoking, then I will strongly advise them to stop. But I probably wouldn't not operate because they were still smoking. But you know, I think we know that smoking impairs healing in every other, you know, part of the body. So it's not a contraindication to surgery, but you do you know, read them the Riot Act and tell them it's not going to work. And you know,
you mentioned in your talk that since you started doing them, you've become more selective about nerve transfers for elbow selection, and you mentioned things, but could you just clarify where you perhaps wouldn't go for a nerve transfer?
Yeah, so if I think a patient is suboptimal for a nerve transfer for elbow, then we'll just offer them a deltoid to triceps. So the high level patients, the patients who've started off as a C4 or a C3 and have recovered to a C5, maybe heavier limbed patients, maybe their EMGs don't look as favorable, the teres minor comes off the posterior division of the axillary. So if their posterior deltoid is not strong, because it's sometimes hard to know with teres minor, are you examining teres minor, or are you, because you examine external rotation, is this infraspinatus, is this teres minor, is this posterior deltoid? All those muscles are in the same spot anyway. How can you tell which one is which? So if the posterior deltoid is not strong, then that's very strong circumstantial evidence that your teres minor probably won't be working either. So it's just that higher level of injury, and late as well, more than 12 months. So then they just get deltoid triceps, very reliable, and just a bit of more of a pain in terms of their post-operative rehab.
Do you use EMG for teres minor?
Yeah, we do.
Right.
But you know, like a clinical examination, I don't know that you can be, in fact, the patient we did today had that we ended up doing a variation for their elbow extension because their EMG said their teres minor was in pretty good nick, and examining them, they had good external rotation. But they were a high level of injury, and we knew that there was a chance that their teres minor wouldn't be ideal, and it did not stimulate at all. And so, in fact, today, for the first time, and I've never done this before, I actually stole some fascicles from the anterior division of the axillary and put them onto the triceps. We didn't want to do a deltoid triceps in this particular patient because he was on full anticoagulation and was not allowed to come off it because of a series of strokes that he'd had. He's actually a young patient, and previously been treated with some sort of stent where a little piece of the stent, a little piece of the balloon was left behind in his vertebral artery. And so this patient has these funny episodes and turns and strokes and faints, and possibly actually was responsible for his quadriplegia because he was riding a bike at the time and fell off. So a very unusual situation. We didn't want to be putting strippers up his legs to pull out tendons, and he's anticoagulated. We wanted to do it with nerves. We knew that he was, his teres minor weren't necessarily going to be working, and they absolutely weren't. There was just nothing going on there at all. So made the decision to take but it's about maybe 30% of his anterior division of his axillary and transferred that to his triceps. So certainly not an ordinary day's work, but that's what we did today. Yeah.
So when you consent these patients, do you always say to them, look, it may be, we may have to do something?
Absolutely. We always will say to patients that we may change the plan intraoperatively, and it's really important that you say that, because it just saves you a lot of talking afterwards, explaining why you deviated from your plan.
Okay, so one of the things I wanted to ask you about is the donor side morbidity, particularly donor nerves from around the shoulder girdle. Have you? Now, I mean, it's now been 5 years, like you say. Do you have any sense that actually is all okay? It's not a problem at all.
Yeah, I do think it's okay. I guess maybe I'm not an orthopedic surgeon. Maybe I don't examine my rotator cuff stability as well as some other people would. I know there was definitely that concern raised when I first presented this, that we're going to get rotator cuff tears and by denervating teres minor, and we haven't found that. It doesn't seem to be a problem. And of course, external rotation is strong with posterior deltoid and infraspinatus. So, all of the nerve transfers that we do in spinal cord injury are designed so that there's no donor defect. And the only time that we've run into trouble, and it's never, thank goodness, been a long-term problem, is when we're doing supinated a pin. So we're doing hand opening, and then at the same time, we're taking ECRL and moving it to the front and plugging it in as a tendon transfer to the wrist. So now you've got a tendon that's pulling across the wrist that used to be a wrist extensor. You've taken them down to one wrist extensor. You've fiddled around with the nerve to that wrist extensor around where your supinated a pin nerve transfer is, and you've then moved that tendon from a tendon that's pulling the wrist in that direction to a tendon that's effectively pulling the wrist in that direction.
You mentioned earlier that you use telehealth. I'm interested to know whether you think you can say how good your clinical assessment and decision making be if you can't actually physically examine a tetraplegia.
Sometimes it is clear that we can definitely help, we can definitely do something, but the detail of what we do, we would not be able to decide maybe until we met that patient. But, if you know that, the wrist extensors are working and someone can demonstrate that the wrist extension is really strong, you've got some donors there. If you can demonstrate that pronation is present, then you can be even more sure that your wrist extensors are strong. And so therefore you can offer them, tendon transfer, ECRL to FDP, or nerve transfer, ECRL to AIN. When patients have got spasticity, I think it's super hard to make an assessment via telehealth. That really complicates things. You really need to have hands-on to feel how much the tone is interfering. But I reckon in a standard, complete C5-6, you could definitely say. So for us, we do see patients. I mean, Australia is a big country. We get referrals from all over the country, and a lot of the time we can say, yes, you definitely will need surgery. We can make that assessment, and so that they can fly in for the surgery. Or no, we don't think that you qualify for surgery. You've got nothing that we can work with, because that's really the bottom line. Do you want them on a plane or don't you? And then you make the final plan when you see them before, and also, as we said before, intraoperatively. Sometimes things need to change intraoperatively. But generally speaking, if you examine a patient and you can feel that donor muscle working, it's generally good enough to use. You don't generally get any surprises on the EMG. You don't usually, if you're thinking this muscle seems to be working, you don't generally get the EMG back and go, oh my gosh, that's just totally not what I was expecting. It correlates actually very well. The donor nerves and the EMGs are never normal. Okay, you never get, almost never. They've always got some slight, 1+ of fibrillations or a little bit of reduced recruitment. That shouldn't put you off. If you've got, markedly reduced or discrete recruitment and 4+ of fibrillations, maybe go and examine them again. You'll probably find that maybe you got your examination wrong. Generally speaking, I don't find that the EMG necessarily, helps me. In fact, today it gave us a false sort of sense of security. I don't actually, I mean, we do it for all of our patients, and I look at it for every single patient, but I haven't found that it changes our management. A good clinical examination is what you need to determine whether, and a knowledge of the history of that muscle, how weak it was after the injury, and has it recovered or not. Those two things, the history of that muscle and a good clinical examination of that muscle, will tell you if it's a good donor nerve. And then a recipient nerve, if you're early enough, it doesn't matter so much if it's lower motor neuron denervated or upper motor neuron. But if it's late, and you can tell the patients who will benefit from a late nerve transfer by putting electrical stimulation on their surface electrical stimulation on them. So say we're thinking about doing a supinated or posterior interosseous, we'll put the electrodes on the forearm and stimulate. If their hand opens up, then they're a candidate. Again, doesn't matter so much what the EMG shows. Doesn't matter if you do an EMG and it shows there's some recruitment or no recruitment, or some fibrillations or no fibrillations. If they open up well on stimulation, that nerve is alive enough for you to plug into. And the latest that we've done has been 26 years with hand opening. Not good hand opening. It's about 1 MRC grade less on average than early nerve transfers.
Do you think that and other techniques can prolong the life of a denervated muscle?
Sorry, what was the first part of the question? What techniques?
Yes, is that something that might prolong
FES.
The use of a donor?
Yeah, a recipient muscle, a recipient nerve.
Yeah, sorry.
Yeah. Yeah, so well, we think so, but we would like to show that. So we've actually got a project that's due to start, which will also be another 5-year project, where we are looking at adding FES to the preoperative management, and then comparing outcomes and histology of those nerves. Comparing them to the outcomes and histology of the nerves that we had for the last project.
Great. So
yeah.
Time is getting on a bit. If we carry on, you'll be here all night. But I do have a question. I've been fascinated by your journey since you started doing this over the last 9-10 years, about how you've honed your patient selection criteria. And you talked about, you know, the initial level of injury being a contraindication now. But I wanted to just pin you down on the timing. So your patients in the publication were anywhere from 5 to 15 months.
Mm-hmm.
When the kind of 6 to 12 month timing, how do you select which ones to go for it and which ones to just do tendon transfers?
Okay. So in terms of timing, in a complete injury, ideally, I want to be operating between 5 and 6 months. Sometimes that it's not possible, you know, and so because you've got lots of patients that are needing surgery or you can't get access or whatever, and so up to 12 months would still be acceptable. In terms of how do you, so you're saying, how do you go for it with nerves? You mean as in you operate early as opposed to waiting and giving them time to recover? I think that at 6 months in a complete injury, you pretty much know what they're going to have functionally. At that point, if a muscle is not moving, or if a muscle has got the tiniest flicker in it, but nothing more, it's extremely unlikely that muscle is going to recover enough to be functional. Mm-hmm. And that's work's been done before. I mean, yes, you're more certain at 12 months, but it's a very high percentage at 6 months. If a patient is looking very lower motor neuron in picture, you know, their recipient nerves are looking, their forearms wasted. When you stimulate, you can't get those muscles to move. They are ones that you need to think about doing earlier rather than later. If someone's got a very upper motor neuron picture, and you know, you put the electrodes on and the hand goes up, and you put the electrodes on and the hand closes in, you can afford to wait, because those nerves, those neuromuscular junctions, those muscles are being babysat. So if you're not sure and they're stimulating well, you can sit back and give them a little bit more time. Does that make sense? Yeah. And then the other thing to say is, just to pick up on your first comment, that the higher level of injury is a contraindication. I just want to stress again that it's not a contraindication because those patients are so in need of any improvement, but your prognosis for them is more guarded. But I would still encourage you, and we still do. In fact, sometimes I'm thinking to myself, why don't we just say no? Just sometimes say no. But because you're working on these patients, you're thinking they have just got nothing going for them. But every time they get something out of it that makes a difference, and I go, right, that's why I do it, because it makes a difference. So it's a different expectation you have for that patient, but you should still think about doing it anyway, because the morbidity is so low. You know, the risk is really so low. They don't lose function because the nerve transfers are designed in the right way. And then generally, in terms of tendons and nerves, I mean, you know, I think hand opening, there's no equivalent tendon for hand opening, right? That does as well as supinated pins. Supinated pins are a complete no-brainer. Nerve transfers for triceps are super good if the patient's ideal, and if they're not ideal, do a deltoid to triceps. And then for grasp and pinch, maybe do one hand of each. So you give the patient then has both. They have the power and the early result of a tendon on one side, and they have a hand that opens that they can interact with socially and use electronic devices with on the other. And maybe once we get better at doing the double and triple nerve transfers, I'll show you that we can make nerve transfer hands stronger than tendon transfer hands, and then we might be doing nerves on both sides. But those are only for low-level patients. You know, you've got to have the donor nerves.
We're going to finish up with one last question. This is from one of our delegates, Destiny Links, and she says, thank you very much. And how did you choose which limb gets the tendon transfer or the nerve transfer?
Oh, that's a really good question. We explain to the patients how those two limbs are different, and then ask them. Okay, so somebody who is, it depends on their dominance and what they want to do with that dominant hand. So if their dominant hand is a hand that they want to use to wield, you know, tools and make things, then we need to put tendons into their dominant hand. If there's somebody who's working more on a computer, then we put nerves into their dominant hand. Sometimes also though, I will, all things being equal, pick the better side for the nerves. So the lower level injury. If nobody minds, and it's not too much of a difference, you know, then I will say, well, I'm putting my hand up for, I want your left side. Because I think we're going to do better with nerves on the left than we're going to do with nerves on the right.
Thank you very much. As James said, we could carry on asking you questions, but I think we do need to draw it to an end. You've had a long day, and we really appreciate you coming to talk to us today. Thank you very much.
It's been a pleasure. Thank you very much.
All right,
Okay.
see you in
Bye-bye.
person soon. Take care.
Thanks. Bye-bye.
Thank you, everyone. Bye.
Bye.